Good afternoon, everybody. Welcome to the Academy of Medical Sciences Lancet International Health Lecture for 2025. It's great to see so many people here in the room and also so many people who I know are registered online. My name's Tom Solomon. I'm the International Vice President at the Academy, and I'm a clinician based at Liverpool, where I'm the Director of the Pandemic Institute. The Academy, put your hand up if this is the first time you've been to one of these lectures. Oh, fantastic, okay. Put your hand up if this is the first time you've done anything with the Academy. Brilliant, okay. Put your hand up if you think you're in the wrong room. Okay, well, for those who are not familiar with the Academy, it's the UK's independent expert voice for biomedical and health research. And our mission is to help create an open and progressive research sector to improve the health of people everywhere. What that means in practical terms is we do three things. We work on policy and support policy initiatives. We help career development, particularly academic careers. And then we also fund stuff, particularly academics, but particularly networking type grants. And we do all of those three things in the UK, but we also do them internationally. And one of the most important things we do in the international space is the International Health Lecture. It's a platform for leaders in global health to discuss topics of international significance. And this is the list of lectures we've had over recent years. It's actually been going since 2004. And for the last 7 years, we've been delighted to do it in partnership with the Lancet. What's going to happen today is we're going to have a lecture of 45 minutes. Then we're going to have a panel discussion with some excellent panelists for about 20-25 minutes. And then there's going to be some Q&A, both for people in the room and people online. So think of your questions as we go along. People online can post their questions. And then I think there's a technical voting system where you can uplift the questions of interest. It's great to see so many people here. My co-host, Richard Horton, is going to now introduce our speaker this year. As you will have noticed, Richard is not in the room. He's, we try and do things hybrid. We try and minimize travel. Sometimes that means less international travel to keep the air miles down. And sometimes it means less travel from Hampstead into central London. And I will let Richard explain why. Richard, over to you.
Tom, thank you. And first of all, apologies for not being with you in person. A fall has left me temporarily indisposed. So my health lesson for the evening is beware wet autumn leaves on London streets. It's my great pleasure today to introduce our speaker. Known to many of you, I'm sure, Professor Quarraisha Abdool Karim. Professor Abdool Karim is an infectious diseases epidemiologist, an associate scientific director at the Centre for the AIDS Programme of Research in South Africa, better known as CAPRISA, which I'm sure we'll hear more about this afternoon. She's the John C. Martin Chair in Global Health, Professor in Clinical Epidemiology at Columbia University, and the Pro-Vice Chancellor for Health Sciences at the University of KwaZulu-Natal in South Africa. She's made so many seminal research contributions, it's impossible for me to summarize them in a brief introduction, but they span 4 decades of work, and they really have substantially shaped the landscape in global HIV prevention, treatment of TB in HIV, and most recently, the pandemic COVID-19. Through her Columbia University Southern African Fogarty AIDS International Training and Research Program, she's played an absolutely central role in building the science base in Southern Africa, to enhance responses to HIV and tuberculosis. And she's been, through this program, responsible for training over 600 scientists, which is truly astonishing. She's currently the president of the World Academy of Sciences, the very first woman to lead this organization, and that focuses on the advancement of science in developing countries. And since 2017, she's been the UN ambassador for adolescents and HIV. She was recently elected a Fellow of the Royal Society. She's also a Fellow of the African Academy of Sciences, the Royal Society of South Africa, and she's an elected member of the US National Academy of Medicine. She is a prolific author, as you can guess, and a prolific public speaker. And her work over those 4 decades has been recognized by many awards. The L'Oreal UNESCO Women in Science Laureate, the Gairdner Award for Global Health, the Lasker Bloomberg Public Service Award, and the very highest honor, an award from the African Union, the Kwame Nkrumah Prize. We are delighted, we are honored to have Quarraisha with us today, and her lecture is entitled Lessons from Africa, Health Diplomacy in HIV Prevention. Quarraisha, the floor is yours.
Thank you very much, Richard, for that very warm and generous introduction. So, Professor Horton, Professor Solomon, our esteemed panel members, the staff at the Academy for Medical Sciences, a really great team, and also the team from the Lancet journal, distinguished guests, friends and colleagues, greetings. It's a singular honor and privilege to be here today to deliver the International Health Lecture and to be part of a very important tagline of about generating knowledge for the benefit of everyone, everywhere. So today I'm going to talk about lessons from Africa, health diplomacy in HIV prevention. And I should say the invitation to deliver this lecture came about 8 months ago, and it's been a wonderful journey working with Professor Solomon and his team, and also with the Lancet team, with Richard, to try and figure out what this lecture should focus on. And it's been a little bit of a work in progress. I think even as we gather today, the work in progress continues, because I think we are gathered at such an unprecedented time in history, a very volatile period, and there are so many challenges. And there was a time when I used to think about long-term planning, was like a couple decades, and now I wonder, what will happen in the next 3 to 5 years? Would we be here? And so on. But I do want to say I've appreciated the guidance, the discussions, and all of that as we've worked to produce the manuscript published now and available, and also to work on the slides for this lecture. But I do want to say that whatever I say today, I take full responsibility for. Now, also in the work that I will be presenting in the next 45 minutes or so, I need to acknowledge a lot of people. So every time I say we, it's many royal we's. This journey that I'm going to share with you, it's family, it's mentors, it's very generous teachers, and it's also a large research team at CAPRISA, and also other networks that I'm part of. Many collaborators, many donors who support the research, the volunteers from communities we work in who participate in the study, the various government officials, etc. So it's a very couple villages, and I do want to upfront acknowledge each of them who've been part of this very exciting journey. So this talk is going to be in 3 parts. And the first part, I want to reflect about this moment of time where we gather, and it's not going to be exhaustive, but I do want to highlight the importance of science, the forward-lookingness of science, to underscore we are here today and we can celebrate so much in life as people because of scientific advances that we've made. And I think that times of adversity are not uncommon. It's part of life, part of our ups and downs. And what's really important is how do we manage that? And I think as scientists, we have a particular responsibility, and it's how we respond that actually shapes how society at large actually copes with these ups and downs. In science, we take a lot of risks, and some of them, and most of them, I would like to think, are very calculated, but we never know what the outcome is going to be when we seek to generate new knowledge that's needed. And sometimes what we have is failure. But I think the one thing that keeps all of us going as scientists is hope. And it's hope for the future that we need more today than ever. The second part of my talk is going to be around the impact of three pandemics that we have, and all of them are ongoing epidemics and pandemics, in particular HIV, TB, and COVID-19. And here I'll touch on some of my personal journey over about 4 decades, and what are some of the lessons we can draw. And when I draw on those lessons, again, I have to say it's many, many people have contributed to these advances. How do we really learn from there on what partnerships and collaborations look like, and how do we take on wicked problems and find solutions to them? And then lastly, just to wrap everything up, to think about the road ahead and what is it that we need to be doing to ensure that we have sustainable futures for generations to come. So, okay. So this is not meant to be an exhaustive list, just identifying some of the greatest threats that we are facing. And I think we need to contextualize these threats within one very important framework we have, which is the Sustainable Development Goals. And these 17 Sustainable Development Goals that we've adopted as member states is really the world's greatest hope for the future. So we have to keep reminding ourselves, we're one Earth, we're one planet, and what we're learning increasingly is that it's very fragile at the moment, and we do need to use these tools and frameworks that we have as we move ahead. So right now we have a convergence of multiple things. One of them is climate change. We've seen how the 1.1 degree global temperature rise that we see projected to be 3 to 4 degrees by the year 2100. Some of the evidence that's coming through is shifts in terms of geographical distribution and seasonality of vector-borne diseases. There's a whole lot of health impacts that these changes are having that we haven't even started to touch the tip of the iceberg. So for the young people in the room, lots of work to be done in terms of the impacts. But that is really one of the biggest threats that we have. It's impacting us in so many different ways. Not all of that we have the solid evidence for, not all of that measurable. The second is global inequalities, and that's one of the big reasons why we have the Sustainable Development Goals. We have 1% owning 46% of the wealth and 700 million in extreme poverty. And I mean, I am dumbstruck often to see how this unrelenting quest by a few for power and wealth puts everything at risk with equanimity. We can talk more about that in the Q&A, but it's also linked to the third, which is wars and conflicts. And in the context of very uncertain geopolitics, we have 54 active conflicts with at least 100 million displaced people. If we needed peace and to promote peace at any time, now is really the time. But Not only do we have these wars and conflicts resulting in many displaced people, it also becomes the place where infectious diseases thrive. And we know infectious diseases in one part of the world and in low middle income countries has become a global threat now, and we see that over and over again. But one of the issues around wars and conflicts is that it impacts our health facilities, already overburdened, already under a lot of stress. We see scientists being lost. We see education disrupted. There's so many effects and impacts that we're seeing. And the wars that we're seeing today are unlike any of the wars we've ever seen. And they're not the boots on the ground type, but it's more serendipitous, it's more under the radar screen, and we don't know a lot of what's going on, but we are seeing it increasingly. At any other time, I think we would be calling this World War III. I'm not sure why we haven't done that yet. But pandemics, we all have lived through COVID-19, and we've seen the impact of over 7 million deaths in just a matter of a few years. We've seen the economic costs. It's about lives and livelihoods. $12.5 trillion is what we think the cost of that one pandemic is. And then in the midst of all of this, we have this very exciting new development of artificial intelligence, machine learning, and large language models. And somehow, with that, we're seeing more challenges than opportunities for leaving humanity better. And the one particular example is around infodemics and the disinformation that we're seeing impacting democracies and elections, but also influencing and reducing the influence of science in society. So many things, not even meant to be exhaustive. I'm sure if we take a survey, there'll be a couple more really important challenges we can put there. But we're also seeing changing global demographics. And in particular, I wanted to highlight by 2050, 40% of the world's children will be in Africa. Industrialized countries are facing aging populations and declining enrollments at tertiary institutions. The traditional north-south dynamics in higher education is undergoing profound transformation as one example. And low middle-income countries are no longer at the periphery. They're actually central to the future. And time doesn't allow me to share with you some of the new statistics in terms of where knowledge is being generated and where the new stuff is coming through. And there's been major shifts there. But we're also seeing disease transitions. With industrialization, we've seen how the North has been able to reduce infectious diseases and shift more to diseases of aging or longevity and more chronic conditions. In contrast, in low middle income countries, we still see infectious diseases dominating, but also a rapid rise of non-communicable diseases. And then in low middle income countries with the recent Mpox outbreak, we've seen, for example, how the youthful populations face vulnerability. So not having had smallpox, the Mpox impact have been very different. So we just compare, for example, global burden of disease using the 2019 data, looking at North America versus Africa. You see in this map, what I've been talking about, the shifts of what you're seeing in the north versus what you're seeing in the south. And you can see how the orange, which is the kind of diseases of poverty and infectious diseases, much stronger in Africa compared to that in industrialized countries. But not only do we have these differences, but also there's a very high burden of disease in low middle income countries, and this just gives you some indication of that distribution of the burden. And if we have to predict what are new things that we have to worry about, I mean, there's the usual culprits, but just to give you some indication, in Africa alone yearly, between 2001 and 2022, we have seen 102 public health events reported. Most of these have been substantiated, and we are seeing In Africa, just in the WHO Africa region, 92% of these 2,234 incidents have been infectious diseases related, 30% to zoonoses, and 5% due to humanitarian crises. And then just to touch on this, because I think all of us are pretty familiar of how AI is impacting human society and at an unprecedented pace. Importantly, unlike, for example, if you were trying to develop a new medication, there are regulatory frameworks that guide where you work. In this space, there are actually no guardrails. We're starting to see some coming in. It's a little bit like closing the barn door after the horse has bolted, but notwithstanding, what we're seeing is labor market restructuring. We're seeing issues around data privacy and security, and then the impact of misinformation and deepfakes. Just the one example, for in May 2023, there was this fake AI image of the Pentagon explosion, which went viral. That resulted in the stock exchange index of S&P 500 to drop substantially. So this is not just about the influence of science, but it's the influence and impact on society, and not all of those are very positive. And this whole piece about anything goes, you know, it takes freedoms to new levels, but freedoms also come with responsibilities. And whether it's bots or whether it's people, social media, the amplification counts and not accuracy. In fact, some of the fact-checking that some of the tools had has gone. So we've got minimal fact-checking. There's no editorial quality assurance for ensuring what is true. And there's like a rapid blurring between what is truth and evidence and what is political opinion, and this kind of aspect which is having huge impacts. And then you really, and people hide behind anonymity. And anonymity is one thing when you're doing peer review for journals, but quite another when you are spreading hatred and division, and where specific groups are being targeted. And who is this person? You know, got a PhD from Google or from WhatsApp or whatever, X or so on. And worse is it's become a new profession. It's income generating huge amounts of money. And anybody who has an axe to grind, well, it's a free for all. And this is something that we have to really consider as a global community. I want to touch a little bit about health sovereignty, which is a very multifactorial thing, but very much linked. And I wanted to particularly look at it in relation to the Sustainable Development Goals, the importance of access to care, the importance of strong institutions, the importance of national strong healthcare delivery systems, etc. It really underpins several Sustainable Development Goals. I wanted to highlight 3, 5, 9, and 17. And how important resilient health systems are to drive economic stability and equity, and then to say that, you know, the sort of time when aid was acts of charity and generosity is really beyond that now. And it's become a strategic necessity and important investment, in that when we have good science, the whole world benefits, and I hope to give you some examples of that. I also wanted to touch a little bit on political diplomacy versus science diplomacy. Some of our panel members will expand on it, but really the importance about science that we need today that unites rather than divides, and science diplomacy that enables scientists and implementers to bridge gaps even when political relationships are strained. And I'm going to come back to that. But I wanted to just end this section talking about effective partnerships. And it is really key to our ability to cope with this period and to find ourselves in a better space and to ensure that sustainable future. And so there's some fundamentals about partnerships. I think regardless of whether you're a scientist or anywhere else, when you're partnering with someone, it's really premised on mutual respect and trust. Secondly, you have to value that each partner has a contribution to make. And while initially those contributions may be unequal, there's a whole lot of ways we can work towards equity, and training and capacity building in science is important, filling skills gaps. But more importantly is that when these two bodies come together, these two entities come together, these two individuals come together, it's really that you can accomplish more than what you could accomplish individually. So it's that synergy that's really important. And that the outputs that come out of this type of partnership brings value, added value, and also needs equitable benefits to derive from it. And right now, we are dealing with multiple complex challenges. And these complex challenges, one, underlie and underscore that we're interconnected with a shared vulnerability, but also that we have to think very differently. We have to get beyond interdisciplinary, multidisciplinary thinking to new levels of systems thinking that is still unfolding, unraveling, that we need to define and articulate better. So if we take the Sustainable Development Goals, let's look at how are partnerships doing here in terms of sustainable futures for all. So, well, we do have the shared vision and unity of purpose with the 17 goals and the target for 2030. But, you know, we are not doing a great job in progress, as we know from the midterm report that was released 2 years ago. So is science a public good benefiting all of humanity? Because that has to be one of the key pieces. Well, let's say we're not yet there. And I think we're still competing with commercial interests and geopolitical barriers as two considerations. Do we have mutual respect and trust? And I think that's gotten a lot better between scientists, and many governments now have chief science advisors, and we're doing a lot more evidence-based stuff. But I think we have a lot more bridges to build between industry and the public and communities. And so here we're still seeing some divides there that need to be bridged. And do we have a win-win situation from coming together? And I'd say we still need major paradigm shifts here. And we have to really think and act differently. And how our investments in strong research institutions and strengthening healthcare delivery systems towards universal health coverage is one common project we can all be thinking about. So I'm going to move on now, and I was told that there's some very young, early career scientists here, and they want to know a little bit about my career trajectory. So I have one slide, and I think the rest of it you're going to pick up from other slides. But just to say that I'm from South Africa. I was born on the East Coast, just north of the city of Durban, in a very small town that was set up with where the sugar mills were based, and Indians were brought to South Africa in 1860 to work on the sugarcane plantations, and I thank my great-grandparents for getting on that ship and wanting to explore a new area, and they put a very high value on education. So even though we had the discrimination from the apartheid state eras, they did invest a lot in education. I'm here today because of that high value they placed on education. I knew from a very early age I wanted to be a scientist, and I didn't want to be a clinician. So my first degree was a BSc at a very Indian university called Durban Westville. I then spent a couple years learning more immunology, hands-on deck kind of thing, and did a BSc honors degree in medical biochemistry at the University of Witwatersrand. I did my master's at Columbia University in 1988. And just remember the year, because I'm going to come back to why that year was important. I came back to South Africa after that year at Columbia University and being in New York. So between 1989 and 1994, I was a scientist at the South African Medical Research Council, and during that time established the KwaZulu-Natal AIDS program, It's another part that I'll return to, but and I'm not going to get distracted and get ahead of myself. The other milestone was in 95 to 96, the newly elected Mandela administration appointed me to set up the National AIDS Program. So I was very young, had done a couple years of research, and now I had to set up a whole program. They say it was a very humbling experience. I learned a lot about making recommendations at the end of a manuscript on the policy that should be in place and everything else. So I learned a lot about policy formulation and programming then. And then in 2002, together with the other royal we, which is Slim in this case, my life partner and collaborator for this period, we co-founded the Center for the AIDS Program of Research. Tell you more about that. And then more recently, you heard in Richard's introduction, I'm currently the president of the World Academy of Sciences. So I just put a couple of those highlights there just to show how my knowledge of what science and knowledge generation is and how that links to diplomacy has been evolving, and that's like one of that work in progress. So in 1981, we had this report from the CDC in the US around this new cluster of cases of men who have sex with men, who had this new phenomena. It was even called the gay men's disease. And later, much later on, we started to see actually there was something similar going on in Africa, in West Africa, East and Central Africa. And what we were seeing was young people dying. And, you know, in life, that's supposed to be your honeymoon period. You don't get sick. You just do what you want to. You're supposed to live your life and set your career paths and have fun and encounter things. But here we were seeing in Africa and also in industrialized countries, young people getting very sick and dying. So we were seeing the face of AIDS. And it took a couple years before Professor Francois Barré-Sinoussi discovered the causative organism, and then from there we saw Bob Gallo and others start to develop diagnostic tests and the light at the end of the day. But that light starting to shine in terms of knowledge generation came from the huge amounts of activism on the ground in places most heavily impacted by AIDS. And I'm going to come back to this nexus between science and activism and global solidarity. So I happen to be in New York, and I'm experiencing this unfolding AIDS epidemic in the Greenwich Village, in the East Side, and then going to the Bronx, going to Harlem, and seeing different faces of this unfolding epidemic. And then also in my lectures, hearing from people in Africa, and I'm thinking, what's happening in Southern Africa? We know very little. So on my return, one of the first things I do is, together with Slim, set up one of the first community-based surveys. And we do this survey because there was very little data available in terms of, do we have HIV? We had some anecdotal stuff. We had some stuff from the mining companies, from workers in the gold mines, and so on. But in the general population, there was anecdotal evidence that something new was impacting the population. So we do this survey, piggybacked onto the active surveillance program for malaria control, and we find the overall prevalence was less than 1%. But the age and sex disaggregated analysis showed us this very unique, what would become known as a unique characteristic of the epidemic in sub-Saharan Africa, which is young women, 15 to 19, acquiring HIV, about 8 times higher rates compared to their male peers. And then we're starting to see infection in men at around their early 20s, peaking around mid-20s. And when we first described this age-sex difference in HIV acquisition, it was met with a lot of suspicion. In fact, the first journal I sent it to the South African Medical Journal rejected the paper. I then decided to send it to AIDS, and AIDS put it on a fast track. So whenever you get a negative, if you believe that data is good and strong and making a good point, don't give up, keep going. Of course, now we have data that's come through, and we continue to see this age-sex difference. And I'll come back in a little while showing how important it is and why it's important in terms of transmission dynamics in sub-Saharan Africa, and why we have this high rates of HIV infection despite very high prevalence rates. Now, when we shared this, the world's attention was on how do we prevent and treat men who have sex with men, and then looking at injecting drug users, and there was some work underway in terms of mother-to-child transmission, how to do that. So there's very little work on what does this mean for young women and how to prevent infection. But I'll come back to that in a few minutes' time, so just hold that thought for now. In 95 to 96, as I mentioned earlier, by now we knew that even though South Africa has less than 1% of the global population, 1 in 5 infections taking place globally was in South Africa. So a disproportionate burden in this newly established democracy. And we were fighting this war with sticks and stones. We had abstinence, behavior change, we had, be faithful, we had male condoms, we had counseling and testing. Much later on, we had medical male circumcision. But pretty much, I'm running a program where literally I can distribute condoms, I can make sure we're doing good screening for sexually transmitted infections and treat the opportunistic infections with advancing HIV disease. And we were really at this time starting to see the increasing morbidity and mortality from that silent spread that we saw in the late 80s and early 20s. And life expectancy was dropping very rapidly. At some point, it had dropped by 20 years. And we still haven't quite got back to the rates of life expectancy pre-AIDS. There was a lot of denial, stigma, and discrimination, which meant that the usual structures for resilience in communities wasn't quite there. And so you didn't, patients with AIDS and families that were being impacted weren't able to count on the usual community support. And we had a lot of, the best we could do was palliative and home-based care. And on top of that, we were having these high rates of mother-to-child transmission, 30 to 40%, and high rates of deaths in infants, so reversing some of the infant mortality rate gains, also deaths in mothers, so the high maternal mortality rates, and then worse with the parents in the most social and economic age range dying was the millions of orphans that were left in child-headed households or skipped generations where grandparents were having to take care. And there was, what I discovered, very little programmatic capacity or research capacity. So that's where my mentor from Columbia comes in, Professor Zina Stein. She had the foresight to apply to the NIH, to the Fogarty International Center, to set up this training program. So she worked closely with SLIM, and we started to do training in research capacity for HIV, and we very rapidly included TB in several countries in South Africa, Botswana, Swaziland, Lesotho, and Namibia. And when I stepped down to try and fill this gap from being director to going back to being a scientist, this was really the program that was so key to building the science base in South Africa and in the region for enhancing responses to HIV and TB. I'm not going to, you probably can read all the statistics on the slide in terms of the impact this had in terms of building institutions and research centers and institutes. I'm going to talk about CAPRISA, but there are several more. But almost every major HIV study in South Africa involves some trainee from this program, and many of the graduates holding leadership positions within Africa or outside, lots of publications. You can see so many, and the very important part was it created really nuclei to build and have a multiplier effect, and really helped to strengthen some of the South-South training and capacity building within Africa and in other countries beyond. So I took this, a select group of photos, because I think if you go around for those online and here, you will recognize a few of those faces, if not more. These are all people who've been through this program in some way or the other. And you know them because they are very important people in different spaces. So that just gives you a flavor. Pro-vice chancellors, presidents of research council, and I can go on and on, the head of our National Health Laboratory Service, and so on. But I'm coming back to where are we with HIV? It's not over, as I said. So in 1996, I happened to be at the conference in Canada where David Ho announces triple therapy. And that really changed AIDS from an inevitably fatal condition to one that's chronic and manageable. But it was there for those who could afford it, and mainly in industrialized countries. In low middle income countries, including sub-Saharan Africa, which had 70% of the global burden of infection, hundreds of thousands continue to die. Life expectancy, as I mentioned earlier, and the impact on society, and often and substantial impact, socioeconomic impacts. And in fact, it was becoming increasingly a security threat. We were on 4-day weeks because of the number of funerals that were taking place and people attending. So around that time, I happened to be elected a member of the International AIDS Society. So somewhat naively, at my first meeting with the International AIDS Society Governing Council, said, how come 70% of the global burden of infection is in Africa? And we've never had one of these meetings in Africa. So very promptly, I was given the task to find a venue in Africa, and we will have the meeting. Well, that happened in 2000, 4 years later, where we hosted in Durban the 13th International AIDS Conference. And it was an incredible time. Firstly, before the conference, our newly elected, democratically elected president decided to question, does HIV cause AIDS? And so we went from a couple registrations to suddenly one of the largest conferences that took place. It was an amazing time around this conference where you really see activism coming together with good science and the building of global solidarity. That was the moment that gave birth to the Global Fund for AIDS, TB, and malaria. It brought drug prices down to affordability. It even had the industry rethinking pricing issues. And part of it was because generic manufacturer was telling us this can be done at $1 a day, and it's now like less than $1 a day. And then we also had the Presidential Emergency Program for AIDS relief. And PEPFAR on its own made an amazing contribution to ensuring rapid access to antiretroviral treatment in the most hard-hit African countries. Today, we have just over 31 million people on antiretroviral treatment across the globe. But where we're failing is in terms of prevention of new infections. That remains a challenge. And if you look at the most recent data from 2024, today we have 41 million people living with HIV. That's just a reminder. We have about 10 million still to be identified and initiated on treatment. And despite test and treat approaches or treatment as prevention, we have about 630,000 HIV deaths, 1.3 million new infections. Another way to look at those infections, it's about just over 3,500 new infections each day. So that's a couple jumbo jets right there. And sub-Saharan Africa has about 50% of the global burden of HIV, and 2 out of 3 new infections are in young women and girls. In fact, when we look at that 1.3 million infections, there are 3 things that are driving it. One is the high rates of infections in Eastern and Central Europe, and then in young Black MSM in most parts of the world, and then in Sub-Saharan Africa in particular, it's adolescent girls and young women. So now, besides having the 13th International AIDS Conference, the founding of CAPRISA also took place during this time. And the NIH had made a new grant announcement, very unusual. It was awards that were being made to foreign investigators to define what they saw as priorities to enhance responses to HIV. And we were the first two grantees to be funded. It was a program grant award. And when we thought about what we should do, the first thing we said and appreciated was that this paradigm in terms of Africa being imbibers of knowledge generated elsewhere had to be changed. And so we said, to tackle the challenge that we have, we won't be able to do that on our own at the University of KwaZulu-Natal. So where are the strategic partners we have? So we went to the University of Cape Town, where Carolyn Williamson was based and had developed a whole lot of virological skills around genomics. Then we went to the National Institute of Communicable Diseases, where Lynn Morris was, and had been establishing some of the immunology research to try and understand immune responses post-infection. We went to the University of Western Cape, where they had a good infrastructure for bioinformatics, and so we're going to do clinical work, we're going to do basic science, we need to pull all of this together, so bioinformatics is going to be key. And then our old partner at Columbia University, where we'd been doing training and capacity building, where we'd expanded from public health training to also doing a lot of lab investigations, and University of KwaZulu-Natal. So that was the consortium that was set up, and that still continues to be a very active 22 years later consortium, and a very productive one in terms of what we've been able to accomplish. CAPRISA also has certain accolades, and in terms of being a center of excellence for HIV prevention for the Ministry of Science and Technology in South Africa. It's the extramural program for studying HIV, TB, pathogenesis, and also a UNAIDS center for HIV research and policy. And then post-COVID, we're also a center of excellence affiliated to the Global Viral Network. But I wanted to share also with you, we had, until a few months ago, about 300 staff. We're now down to just about 240. But the thing is that if you look at the distribution of our staff, it's an 80% women-led organization. And there are only two departments that have men. That's the drivers and IT. Everything else from the top, every department is led by women. And so it's not just, the doers. So we have 15 professors, 9 associate professors, we have 45 PhD scientists, 36 medical doctors, 10 of whom also have PhDs, and go on. And then, we're part of transformation, also trying to make up for the apartheid past. And you can see that's very reflective of the demographic in the country. So when we set up, we focused on two of the most important priorities: the high death rates from HIV-TB co-infection and preventing infection in young women. And then more recently, we added COVID. So one of the studies that we did was the SAPIT study. So when the decisions were being made about increasing access to antiretroviral treatment, we knew you can't put 7 million people, that's just in South Africa, on treatment overnight. So who would benefit most? And what we knew was that about 70% of people with advancing HIV disease had TB. And what was not known at that time is, when do you initiate ARV treatment in patients who have, no, should you do the HIV first or should you do the TB first? The SAPA trial, in fact, defined the timing of antiretroviral treatment in patients with HIV and TB. And anywhere in the world you go today and you look at how HIV TB patients are managed, it's from the data that emanated out of this trial. What we saw was a reduction, 56% reduction in deaths in HIV TB when you have integrated services and you initiate treatment. WHO took that and released a rapid advice within weeks of the data becoming available. It was implemented in South Africa, and we've seen a 32% reduction in TB deaths since these data became available and provided guidance on this. Okay, so now we're going to come back to young women. So that was 1990. This is more recent data from schools, and in these schools data, what you see is that age-sex difference persisting. And we now, with new technology, we're able to do phylogenetic analysis and show the cycle of transmission, and definitively and unequivocally how young women were getting infected from men over 25, who in turn were getting infected from their peers because they had relationships simultaneously with women over 25 and under 25. This was the cycle of transmission. It was published in Lancet, was shared with UNAIDS. It's very much part of the Get on the Fast Track report. You can see a nicer diagram than what we as scientists generated, coming back to the South African National AIDS strategic plan, and with additions of infection pathways, a high priority. So one of the things when we first observed this was we did a whole lot of socio-epidemiological studies in communities, urban, peri-urban, rural, and what we were seeing was that what we had available, those ABCs, none of them were things that gave women any agency. So fundamentally, the root cause was about gender power disparities. We're looking at a technology largely from the women on the ground saying, you smart scientists, can't you develop something that we can use? And so began our quest to find a woman-initiated technology. And so in this blue line, what you see is this exponential spread of HIV in South Africa, and stabilizing at around 28%, and our attempts, an attempt to find a woman-initiated technology. After 18 years of failure, we finally shifted gear. But by then, we had earned a lovely moniker of being experts at failure, and as we walked and went to meetings, etc., here comes the experts at failure. So in providing antiretroviral treatment in some of the communities we're working in, we came across tenofovir and decided to go with an anti-HIV specific agent because it had a good profile and so on. But one of the things we did in consultation with potential users was define the dosing strategy. And the woman said, we don't have sex every day. We need something that we can use when we have sex. So we used all the information and data we had to come up with this coitally related gel use strategy. Our peers were not very happy with it. They published in Nature. This trial was doomed to failure. In 2010, we announced to the world at the International AIDS Conference in Vienna. And this was the first proof of concept of what we now know widely as pre-exposure prophylaxis. And this was just some of the media coverage because the HIV prevention landscape at that time was so parlous. It really was light at the end of the tunnel. And lots of WHO consultations and eventually, the WHO guidelines that PrEP and particularly the more easily available formulation of daily oral tablets of tenofovir with emtricitabine is one new approach to preventing HIV infection in men who have sex with men, injecting drug users, and also in young women. There have been many challenges. I just wanted to touch on one, which is that the drug threshold in women needs to be very high. And because we had a partially efficacious trial, we were able to understand the importance of high drug levels for protection. And so we had to go to the drawing board and figure out what was competing for the phosphates that's needed to convert the tenofovir to its active form. And here we discovered a whole space of vaginal dysbiosis, and particularly how a lactobacilli crispatus non-dominant environment enhanced HIV acquisition, but also reduced the potency of tenofovir gel. And so we're still trying to figure out causal pathways and consequences, but one of the factors is HPV infection. About 75% of our population by age 23 had multiple strains of HPV infection. And the microbiome work has led us to, with others, and particularly the vaccine, the consortium looking at developing a biotherapeutic. We've just completed the first in-human studies, and we say, watch the space for next advances. But I wanted to say that in doing this work, it's a very slow and long process. So this is not quick fixes. And I wanted to use this example of broadly neutralizing antibodies and how we discovered them. And because we had a repository and followed people up longitudinally, we could describe, not just measure the presence of broadly neutralizing antibodies and identify it, but even describe the ontology. How did this happen? What was the stimulation over what period? And then we had this joint project with the Vaccine Research Center at the NIH, and the idea about a biannual sort of injection, a sort of long-acting biological PrEP. But here I wanted to flag this generations of training and mentorship that enabled this journey to happen, and monkey studies and first-in-human studies, but mainly this timeline. 2004, the woman enrolls into a prevention study, gets infected about a year later, and then she's initiated on ART, doing well, and another story, but we then, 2010 start to see BNABs, time moves on, and we isolate and do all of this. And we've just completed the phase 2 trial, and again, watch that space in terms of outcomes. But we continue to focus on those. And I just wanted to not spend too much time on COVID, but COVID happened, and we were all watching this unfolding. So we immediately looked at how we were going to be prepared and to respond, and develop this 8-stage response. We're looking at its impact on services, lockdowns on HIV, TB services, publishing it, going to the ethics committee to say, can't halt these services, can't halt the research, put the mitigation steps in place, use the phylogenetics we developed for HIV to do the sequences with Tullio de Oliveira, who at that stage was on just one floor below us, started to describe these variants of concern, did a whole lot, working with people to develop diagnostic tests, with Vine in particular, and then looking at the impact as vaccines started to emerge, whole lot of things looking at how it was impacting HIV patients and what was going on with non-virally suppressed people. And then this, Omicron. And if I had time, I'd tell you about this paper, because a very special request from Richard, you can't say no, and how we turned this paper around in a couple hours and went live. It's a nice story for TO Q&A. But just to say that I wanted to spend a few minutes just talking about how we assess our research. And I think in most places, you look at output, you look at publications, conference presentations, and so on. We look at, firstly, what is the impact of our research on improving health? And all those indicators that we use, we just want to, it's about changing the world with the research that we do. and the outcomes in terms of are we changing the research space, and then we also do count, because a lot of performance is measured with things like publications, etc. I'll just flag some of it: global science leadership and advice that we provide through various committees. Just to highlight, when the Secretary General Ban Ki-moon had the high-level meeting on AIDS in June 2016, he asked Slim and I to organize the scientific evidence to support ending AIDS as a public health threat. And you can see key people there who you may recognize taking part in the panel before that meeting, and how that data was used as part of that declaration. A lot of support to WHO, to UNAIDS, etc., and in developing guidelines, and a little bit of my work with the UN Secretary General on Sustainable Development Goals and organizing the 7th and 8th United Nations STI Fora in 22 and 23, belonging to academies, boards of medical journals. And I just wanted to flag one thing here, because I think the bottom line, which has those numbers, is our incidence rates of publications in different journals. And it's really about highlighting where we're generating knowledge. And so, you know, when you publish in Nature, Nature Medicine, Science, it's like basic science work. So it's that continuum of research that we're doing, from the basic sciences to the clinical trials, to the public health, transmission dynamics work. And then, so mainly to say, yeah, we track that, and to publish every 5 months in the New England Journal of Medicine, every 2 months in it, and that's just for this year, every 6 months in Science, every month in Lancet, and then some of the more specific IDE journals. And then just to say that our work is not just to publish, but we do a lot of community outreach and engagement, and this just gives you some idea. And this has been something we've been doing right from the outset, about print articles, broadcast, and also looking at the impact and influence beyond South Africa and the add value that we have. I'm not going to talk about awards, but I do want to spend just a few seconds talking about knowledge generation and how we do that in partnership with communities very early on, from the time we have ideas throughout the research process. And then when we have that, and some of the research infrastructure that we have in place. But really the true legacy is the investments we continue to make. This is a small sample of doctoral, postdoctoral students. I think there's a couple of them in the audience today as well, in terms of masters, doctoral students, postdocs, graduates who come in and get experience from what we do. Many people to thank, and partners. And I just wanted to, I think I'm not going to talk about solidarity, but I do want to talk about this global interdependence, the importance of community involvement, the importance of working together across all sectors for early surveillance, evidence-based policy, and how these types of approach, captured by an African concept of Ubuntu, we are because of others, is critical. And I am going to skip all of these things because I think we've somewhat covered it. And to say that to build resilience, we really need much more diversified partnership models. We need more flexible funding mechanisms, localized capacity development, but always also thinking about risk management and contingency planning, and how we promote science diplomacy that is enabling. And then just to end with this, saying that together and using science, we really have an opportunity for ensuring a sustainable future. And for humanity to progress, science has to be truly global and benefit everyone every way. Thank you very much.
Thanks very much, Quarraisha. Absolutely phenomenal presentation. I love the slide on the publications. Was it one per month in the Lancet, and one every 5 months in
Richard should be very happy.
in the New England Journal. Yeah, extraordinary. Okay, so we're going to now briefly introduce our panel members, and then we will hear from them their initial reflections in this space. So first of all, Anders Nordström, who trained as a medical doctor originally before he got into health policy. He is a former Swedish ambassador for global health, has had many roles, including chairing the IVI, the International Vaccine Institute Global Health Advisory Group of Experts. He's a former head of the WHO, and in 2002 was responsible for launching the Global Fund to fight AIDS, TB and malaria, among other accolades, but we'll hear more about them shortly. But we're just going to hear now from our next two guest plenaries.
Yes, thank you very much, Tom. And it's a great pleasure to introduce Dr. Peggy Oti-Boateng, who is the former Executive Director at the African Academy of Sciences. And she's had a long and distinguished career working through UNESCO. She was the Senior Science Advisor for Natural Sciences and the Director of the Division of Science Policy and Capacity Building in the Natural Sciences sector for UNESCO in Paris. And she's been responsible for policies, building science policy and capacity building in the basic sciences and engineering across many UNESCO regional offices, for example, in Harare in Zimbabwe. She was also the head of science at the UNESCO Regional Office for Southern Africa and for the Southern African Development Community. So a big warm welcome to Dr. Peggy Oti-Boateng. And Dr. Mohammad Hosseini is also very welcome. He is an assistant professor at Northwestern University Feinberg School of Medicine in the Department of Preventive Medicine in Chicago. And his research interests extend across many areas, including ethical implications of using artificial intelligence in research and publications, a subject of deep concern to us, research ethics and integrity, and open science and trust in science. He's been involved in and leads various projects in national and international organizations such as the National Information Standards Organization and the National Academy of Sciences. And he is an associate editor of the journal Accountability in Research. Now, our three panelists are now going to give some opening reflections about Quarraisha's fabulous lecture. So why don't we begin with Peggy, I think.
Yeah. Good evening from Nairobi to all of you, and thank you for the opportunity to be here. I really want to thank my sister and my colleague, Professor Karim, for such a wonderful lecture. Mine is only to complement, what she has just said, and looking at how we need to develop equitable partnership to lead the global health funding in Africa. And thank you very much, Prof. Karim, that Africa is not merely a recipient of global health intervention. It is a continent of innovation, resilience, and scientific leadership. And she's demonstrated that from community-based health systems to genomic breakthroughs, Africa's scientists continue to shape the future of global health. Yet despite this, early career, and I'm sure early career researchers are there, and also mid-career researchers remain unfunded, unrepresented, and undervalued. Their institutions are often excluded from strategic decision-making, and their voices are missing from global health. This imbalance is not just unjust, it's not sustainable. And what do we do about it? Just having stepped down, in my career as the executive director of the African Academy of Sciences only Friday ago, I have seen firsthand how governance gaps, when left unaddressed, can erode institutional, credibility and impact. And I have said, even in my handing over, that this underscores the need for structural engagement, shared accountability, and inclusive leadership. These principles must be embedded in every equitable partnerships we build. Therefore, how do we do that? Professor Karim has alluded to what equitable partnerships should look like. But just to echo that, having worked on the global scene and also in Africa and also getting funding from the North, we've seen that equitable partnerships are not transactional. They are transformative. They must be built on shared leadership, African researchers as co-principal investigators, not subcontractors, that there should be fair funding structures, budgets that include overheads, capacity building, and institutional support, respect for local expertise, just like my sister has adequately indicated, and also transparent governance. And I would just want to share with you, two of the models that we have we have in the African Academy of Sciences, which I've led for the last 3 years, is that we have two blueprints, and I'd like to share that with you. And that is the AAS ARISE program, African Research Initiative for Scientific Excellence. It's a flagship program designed in collaboration with the African Union and funded by the AU and being implemented by AAS. It showcases a model of equitable partnerships. And how do we do that? We're empowering African researchers to lead high-impact projects aligned with continental developmental goals. Most importantly, we're also developing world-class African scientists and leaders who are globally competitive, locally grounded, and institutionally transformative. This, we've given them the opportunity to lead. We've given the opportunity to be a voice for science in Africa. The second, model, which I also want to, indicate, is the African Postgraduate Training Initiative. It's a partnership between AAS, the Bill Gates Foundation, NIH, where we place African postdocs in world-class laboratories while maintaining strong ties to home institutions and building a pipeline of globally connected, locally rooted leaders. Having done this, and Prof has really indicated that, the program they have was African grown, but with, that the rest of the world has benefited from. One of the things that we see, in Africa, which maybe with, and I think the Academy of Sciences and the Medical Academy, what we can do is that there is a big gap now for data governance. That for us has become a critical frontier, that African institutions don't own they don't own most of the data they generate. This has created ethical problems. And I think the onus is on us as academies to uniquely position to lead in this area. We must set ethical standards for data use and advocacy. We must also build capacity for data stewardship and digital infrastructure, especially my colleague has indicated that AI. We also have to look at that and also convene multi-sectorial dialogue to align research with public health for all of us, even policymakers, scientists, and various associations. And I'm pleased to see Lancet, involved in this, and other publishers. What can they do? We entreat them to elevate Africa-led research and perspective. And thank you very much for publishing every month, something from Africa on HIV. But we should have others, other areas, like non-communicable diseases, malnutrition. And I'm sure you've done that. Worked a lot with you in terms of, infant pediatric nutrition. A lot of that we need to, publish. And also the relationship between climate change and disease, disease resilient, also have to look at that. And thank you so much. And also need to promote inclusive editorial practices and authorships. We need to see more Africans as authors of a lot of the things you publish. They shouldn't be just on the fence, but they should be part of the decision making. And this comes from my experience from UNESCO on the global level, in policies. What we have designed science diplomacy and also open science, but most of the time we don't see the Africans there. This is what will entreat, Lancet and other, publishers, to assist Africa to do that. But we also want to, entreat on them to support open access and equitable dissemination of knowledge. And in closing, we would like to call for joint action. And I like the phrase from my sister that when Africa leads in science, the world benefits. True, yes. The future of global health depends on Africa's scientific leadership. If we fail to fund it through equitable partnerships, we fail the global community. So let us build collaborations that, uplift, funding models that empower, and systems that sustain Africa's next generation of health innovations. The future is Africa. So let us all invest in institutions, especially our academies and universities, that safeguard knowledge, promote peace, and ensure that science serves humanity with integrity, and that science serves Africa that we want. Thank you.
Dr. Hosseini, please.
Thank you so much. It's a great pleasure and honor to be here. I hope that you're having a good day wherever you are and what time it is where you are. So I'd like to talk about a whole different aspect of this ecosystem, and that's about trust in scientific knowledge. It's a huge topic with lots of nuances, so I'm going to keep it really high level. A few weeks ago, I was asked by the organizers to provide a quote for social media, and I'm going to just recite the quote that I provided as an opening. I said, quote, "Fostering trust in science requires well-informed, collaborative, and critically thinking communities supported by mechanisms that ensure transparency and accountability." End of quote. It's a mouthful, but I'll try to briefly touch on the first part of it, which is about well-informed, collaborative, and critically thinking communities. In my opinion, when thinking about trust in science and scientific knowledge and how to advance it, specifying who is being asked to trust and what we mean by science are super important. In terms of who is being asked to trust, I think we need to specify whose trust is missing and what factors have contributed to their loss or lack of trust. For example, in a recent survey, more than 71,000 people in 68 countries were asked how much they trust scientists and what issues they want scientists to prioritize. I'm going to share this study here on Zoom for those who are online. The study found that citizens in two countries had an exceptionally high trust in science, and these are Egypt and India. Among the industrial countries, the US ranked number 12, UK was 15, the Netherlands was 40, and Germany was number 44. And there could be many explanations for why people in more developed countries are less trusting or, say, more skeptical. And each case, I think, should be investigated separately in conjunction with social and political landscape of that country. The study also found that people want scientists to prioritize public health, which is, what the topic of this conversation, but also energy problems and poverty. But unfortunately, they believe that scientists are not really working on these issues. Regarding what we mean by science, for the sake of argument here, let's just agree that science is a systematic method of investigating the natural world and humans, okay? But the ecosystem we have now is dominated also by an industry of science. And what is generally accepted as scientific work, for the most part, comes from research conducted in affluent institutions in the global north, and is also intertwined with all kinds of financial or other interests. And in many contexts, so like, say, engineering, it is mostly concerned about marketability of ideas, which could make lay people believe that science is an elitist entity and concerned about making more money. Whereas I and many other ethicists and philosophers of science believe that a scientific approach is about critical thinking and careful assessments. And that may not necessarily happen in a university in an affluent country or be motivated by external interests. In fact, I think history of science shows us loud and clear that curiosity and a zeal to understand our world is what drove amateur scientists for centuries and is now driving millions of citizen scientists or indigenous people who have no affiliation with any institution, but their work is not always recognized as scientific, and it does not receive accolades that are commonly given to those who are based in universities. So my hypothesis is that one way to enhance public trust in science is to not promote blind trust in institutional science, but rather to promote scientific literacy and curiosity and encouraging criticism towards the scientific enterprise itself, healthy criticism. I know this may sound counterintuitive, so I'd like to briefly explain my rationale for this hypothesis. Look, blind trust in science is fragile and it can easily collapse. For example, when lay people hear about evidence of misconduct, or I don't know, now recent years we hear a lot about AI generated paper mills and so on, or when they encounter uncertainty or learn about disagreements among scientists, that is also sometimes used by politicians, unfortunately, their trust is easily lost. But trust that is grounded in an appreciation of how science works, what its limits are, and how it may be sometimes self-correcting, I think is far more resilient and is a lot healthier. And when I say we should promote scientific literacy, I don't mean we should teach people more facts about, I don't know, physics or biology. No. I think we should help the public understand the processes of science, like how evidence is gathered, how peer review functions and sometimes fails, how we build on each other's work, and why skepticism is so essential. We should create this awareness about the fact that science is a human endeavor and is prone to all kinds of inaccuracies and unfortunately also bad actors, especially in the way it is sometimes communicated. I'd like to do a little footnote here about communication. I think we have a major crisis of science communication because sometimes we don't communicate our work. We are unable to communicate it. We are not adequately trained in it. And sometimes some researchers and science communication experts who want more attention use hyperbolic or strange statements that confuse instead of informing people. And when people later realize that what they were told was untrue, they get really disappointed, and rightly so. And all of this is in addition to the existence of some malicious actors who spread misinformation and disinformation. So in conclusion, I don't think we should advocate for blind trust in science, even if it is published by famous scientists or in famous journals. But instead, we should promote a healthy dose of skepticism. And one way of doing this is by enabling citizens to question claims and recognize the strength and weaknesses of the scientific practice to foster a sort of more mature form of trust. As an ethicist, my hope is that people can respect science without idolizing it and can critique the industry of science without rejecting science itself. And in this sense, building trust in science is not about shielding it from criticism, but it's about inviting scrutiny and empowering the public to question and participate in the scientific dialogue. And also, let's not forget, involving more people means more eyes, and that naturally increases accountability. I know this is not easy, but there are many really interesting examples, including lay people in science, and I can mention them during the Q&A if we have time for them. Sorry, I think I went over time, but I'm really looking forward to the Q&A. Thank you.
Thank you.
Thank you. I'm not a researcher. Don't have a PhD. I'm a practitioner. I'm very proud that Richard once called me the undiplomatic diplomat in the Lancet. I'm going to speak more about politics and the practical aspects in terms of how to navigate in the space in between science and decision making. When I listened to you, Quarraisha, I couldn't help still going back a little bit to my own history, because three things. I remember when I was a medical student, I organized a meeting in Stockholm in a hall like this in the Swedish Society of Medicine in 1986. The Panos Institute had just published a report about HIV/AIDS in Africa, very controversial at that time. There was one person in the audience saying, this does not happen in Africa. He was from Zambia. And then at that time, President Kaunda had said his son was infected. They called the embassy and confirmed. That's history now. In 1995 to 1998, I was in Zambia, and that was the time of when the WHO program collapsed, and we established UNAIDS instead, without really proper communication, and was quite a big hit to what was happening then on the ground in very many of the African countries. I was also then initiated what we came to call from the Swedish side, the Swedish regional program on HIV, and I was very happy and proud for the many South African partners we had, the Treatment Action Group, many scientists, many activist groups, but also the political structures, both in Southern and Eastern Africa. In 2001, you mentioned I was part of establishing the Global Fund. I've been lecturing, gave a lecture quite recently about the difference in between the pandemic treaty negotiation and when we established the Global Fund. Big difference. Global Fund, 3 times 2 days of negotiation in Brussels. 14th of December 2001, I was asked by Peter Piot and David Nabarro, can you make it happen? 14th of December. 28th of January, we had the first board meeting. I had signed the legal agreement making the Global Fund a legal entity over New Year and Christmas, together then with the chair, Crispus Kionga from Uganda. 28th of January. 23rd of April, we had a board meeting at Columbia University that you were referring to, and we had received 11 meters of applications, and the first round we took the decision then at the board, including then, against the will of the South African government, to provide funding for KwaZulu-Natal at that time. That was a politically, I think, very important decision. I'm going to talk about diplomacy, science, and practice. And a couple of words first around diplomacy. What is that? Some people believe that diplomacy is something for the diplomats in the foreign ministry. I was the Swedish ambassador for 13 years in the foreign ministry. I'm not a trained diplomat. I was speaking to John Nkasonga when he was the ambassador for the US, and he said the same thing. I don't have a diplomatic training. And my understanding and my take on diplomacy for health is that this is about navigating in political processes. I'm primarily working with the political processes at global or regional level, but the health diplomats, they're coming from the private sector, they're coming from civil society, they're coming from governments, and they're coming from public institutions, and as I said, yes, again, the private sector. So diplomacy is about the tricks and tools, how to navigate in that space to be able to achieve something that is better for people's health. Richard might remember then the Botswana process, where we were basically then writing SDG 3 and the political process around that. And when I had a big argument with Margaret Chan at that time, and that was when he called me the undiplomatic diplomat. But that was a good example of, I think, how we organized an informal process, taking that from the discussion around health, taking that to the panel that David Cameron, together with President Sirleaf, chaired around the future of the SDGs. And then they took it to the General Assembly for the formal decision-making. That is how we did it in the past. That is not how they did it now with the pandemic treaty. Then, to be a bit controversial, Science, we speak about science here. There is something called political science as well. We don't speak about that. There is actually a logic to politics. And I'm a medical doctor myself, and many of my colleagues, we don't trust politicians. And we don't believe that there's a logic to politics. And that's really something I would like to take to the table and bring to the table. And what I'm doing right today, I'm leading a program on international politics and diplomacy for health with the Karolinska Institute and the Stockholm School of Economics. We have a program, but we also have 4 research groups now working on this agenda, the interface in between political science, international relations, and public health. There is knowledge and there is research done, but more is needed. So, I mean, it's easy to say, and that just listen to the evidence. When I became the ambassador for global health in 2010, I came to work with my minister. I've never been a politician, but I got more and more intrigued with how politics works. And we came to work very closely together, and I saw what I could give her and what she could give me. And when we began to understand sort of the rules, for me as a technical expert and for her as a politician, we had a very fruitful partnership. So what does this mean in practice? And that is basically what I'm engaging in today. How can we ensure, how can we equip a future generation of leaders with the practical skills and tools? What can they learn in between themselves, and what can they learn from slightly more senior people? What I've learned and what we have in what we're doing, 6 practical skills and tools, tricks. First, you need to understand who is actually in power. Is it President Mbeki? Or is it somebody else? I've written a number of ministers' speeches, word by word. So you need to understand who holds the pen, who is the political advisor, who's really in power in the organization. If you believe that the board is taking a decision, and when you're focusing only on the Global Fund board meeting, forget that. Decisions are taken much earlier. And you need to be able to read that political landscape. And again, being a doctor or a scientist, we think that as long as we put the science on the table, the decisions will happen. Forget that. Second, the importance of informal and formal decision-making, making sure that you understand how powerful it is to organize informal settings, dialogues. I was in Geneva now last week just to listen. We had a dinner together. We brought together the ambassadors from South Africa, from India, from China, from Brazil, and from Germany to have a conversation about the future of global health and the future of what we call the global health architecture, together with the head of Gavi Global Fund and WHO. The informal settings, before, of course, you need to get to the formal decisions, but take one thing at a time. Third, trust. We speak about trust in our networks, but how do you do it? How do you establish trust? How do you get friends? And how do you nurture those friends so that they can trust you and you can trust them? That's an art in itself, and you can learn by also getting ideas in terms of how other people have been doing it. I love, Quarraisha, when you spoke about the risks and the failures. In the program I run, we have a session we call Shit Happens, and we speak about when you fail and how you cope with failing. Because especially in the public sector, we are not used to that. Researchers are, private sector, of course, pharmaceutical industry, they're doing it all the time. But in the public sector, we're not supposed to fail. But we need to take risks, otherwise we will not be successful. And the final one is about communication. We need to understand communication, how to package the message. A lot about when we speak about the evidence. We take, the Lancet paper, no one will read the Lancet, the decision makings. I'm sorry. You need to package that message in a way that policymakers can read. And you need to think not just making it short, but you need to think about what's the political setting, so that this will resonate with the political setting that you are in right now. Don't in some way negotiate the content and the quality of the evidence, but there are ways of packaging information so you can actually come to political decisions. So what I'm passionate about today is that we invest in the future generation, not just in terms of public health and medicine, but also understanding how to navigate in the political landscape, bringing political science closer to public health, investing in networks across the world, establishing communities of practice of people that have an interest. I'm today more or less retired, but we need a new generation of people that have the same interest. I would like to see global health ambassadors in all countries across the world that engage, bringing and bridging evidence, new knowledge to political decisions. And of course, we need more research in this area. I thank you.
Thank you. Thanks very much, Anders, Peggy and Mohammed and Quarraisha. So the floor is now open for questions, either questions or comments in the room or questions and comments online. And perhaps I will take the privilege of asking the first question of anyone who wants to answer. So we've heard various perspectives on this issue of health diplomacy, how to bring around change. None of you focused particularly on the use, or maybe you did a bit, but good to hear more about the use of of the public, because I've found when I give a short summary of science diplomacy, science policy to people, and I guess I've learned a bit over the last 3 years. I think one element of it is trying to get politicians to do things they don't want to do, and then, but a really strong way of helping understand their drivers is they very much respond to the public. So does anyone want to respond to that aspect of it and just say a bit more about that? Quarraisha, maybe, because you did talk a bit about them working with the media, etc.
Yeah, so there are multiple ways of engaging the community, and I think there was a time when we all read the newspaper multiple times in the day and watched the news in the evening, but the new generation doesn't use those tools as much, and in fact they're dying and so on. So I think there's the standard social media, how and where are people accessing information, and I think what's happening is a bit of skewness in the way you access and what you think you're getting, where you think you're getting information from, which is also creating these little bubbles that don't always intersect. But I wanted to talk a little bit more about working directly in communities. And I think in HIV, we started these community advisory boards where you are working directly with potential beneficiaries. And that's like a conversation you're having. It's a dialogue you're having. And I think that Mohammed had some important points around what is the societies we're looking at. It's like, what is science revealing, but also how is it being used in society to adapt to challenges and enable society to rise. And I think it's a very different dialogue. And also Anders was talking about the piece where a lot of science diplomacy is between scientists and politicians. But what we're talking about is the use of science for societal transformation, for sustainability. Then I think we need to define these very differently, and it's not a single thing that's going to do it, but we have to move beyond simple peer-reviewed publications to actually engaging from the outset indigenous knowledge, respecting that, also all the diversity that we have, and the type of critical thinking. Let me stop there, thanks.
I'm just thinking about the role of communities. One of the research projects that we are running or that's taking place right now is comparing 4 case studies looking at what happened with the establishment of the work on the Tobacco Convention, the establishment of a global fund, Act A, and then the pandemic treaty. And what was the role of people and communities in this? If you look at tobacco, it was extremely strong in terms of actually getting the acceptance from people. Here, no one smokes here today. So what did it take to make sure people accepted that we will have smoke-free environments? When I worked at WHO, we decided we will not hire smokers. So, I mean, what changed the attitude, that was really the engagement, the involvement of people. Establishment of the Global Fund, I mean, when we had the first board meeting, the building was, I mean, we had to have guards there because there was so much of activism, shouting, medicines to the people that are dying. So the role of communities and people was enormous. Act A, access to vaccines, much more problematic. And we have different camps working in different directions here. Pandemic treaty, we didn't have that in the same way. We don't have the kind of same movement today from the communities as we had in the past. One of my big passions today is food. Do we have a community, and how do you engage the community in terms of that choosing more healthy food, both for people and for the planet? Much more difficult. So I think the involvement of people and the power is extremely important, but it's difficult.
Okay. Thank you. Mohammed.
Yeah, thank you so much. I think we've focused a lot on how things are not happening the way we want, and that is great. But I also want to mention a few examples of how people are being engaged in really creative and interesting ways, which gives me hope, at least to my generation. I think we need that hope to stay positive and look forward. For example, NASA has this citizen science, lots of citizen science projects that involve basically, people analyzing space data. There's this new platform. I don't know how new it is actually. I recently found out about it. It's called SciStarter. It's basically a platform that allows anyone to find science projects in a wide range of disciplines and join them. And we, like, at least here in the US, I hear about a lot of natural history museums and libraries that are doing local biodiversity monitoring or public health projects, which is really interesting. And I think we need more of these. We need to pay more, oxygen. Sorry, we need to provide more oxygen for these in social media, as was mentioned by Quarraisha. A lot of the people are not really looking into legacy media anymore. Everything is happening on TikTok and Instagram and whatnot. And the attention span of people who are engaging with those platforms is so small that communicating complicated or long messages with them is not going to be helpful. We need help from science communication experts who understand us and can bridge the gap between us and the public. I am a researcher. I have hardly been trained in science communication. I have been taught how to write a paper that may or may not be accepted in Lancet or other journals, but I have not been adequately trained to communicate my research and my science in a digestible, understandable way for the public. So I think it goes both ways. We need researchers who are more adequately and better trained, and also we need people who are more receptive of it. And it just takes a lot of work to do that.
Okay, thanks very much, Mohammed. Now we have some questions in the room. So we've got someone with the microphone here, and then we've got someone with the microphone there. And the deal is, once you've asked your question, just find someone, pass the microphone on if you can.
Okay.
Keep the hands up.
Thanks,
and then
thanks for the presentations. So mine is, my name is Ken Esom. I'm with the Center for Global Health Law at the University of Warwick. And I wanted to ask about the link between, when you speak about health science or HIV science, or science in general transforming society, what you see is the relationship with the legal system. For HIV, for instance, we know now that, we can't treat our way out of HIV or any infectious disease as it may be. But we don't see the same level of progress happening with transforming the legal systems with the rich information that science provides. What lessons have you learned in health diplomacy around this, and especially now where we see a retreat around health, rights, gender, some of these gains that have been made that contributed to the success we saw in pandemic responses or HIV responses? Thank you.
Okay, who wants to go first with that one? Peggy, maybe?
Yeah.
Peggy, did you want to?
Okay, thank you.
Go ahead.
Yeah, thank you very much. I really appreciate that question, particularly with communities. Over the years, communities have been like add-ons. We don't develop, the scientific research with them. And I think this is time to co-design with communities. And secondly, we also need to respect local expertise. Most of the time, even going to a village, even for universities, you go there with all the students, with other professors, without realizing that there are local expertise. And this brings me to the question of indigenous knowledge system. And this is very important, particularly when we're looking at climate change and resilience building, and in terms of even, in health or even food security. And we've always ignored them. I think this is the time to do that. And also publishers should be able to, appreciate the link between indigenous knowledge systems and scientific system. You know, Mohammed talked about citizen science, or, you know, ecosystem science. You cannot have ecosystem without, you know, the local communities. And I think it is time now for us as scientists to value and respect the decision-making and also the design, which can shape a lot of our programs, you know, in research. If we really want the scientists, if we really want the local community to benefit. And I also talk about data governance. We take the data from them. We don't go back to make them benefit from the data. And this is unethical. And we also, you know, as scientists, change the way we use data. We benefit from data without respecting and giving back to those who gave us the data. Thank you.
Thanks, Peggy.
No, just give another example in terms of the links in between evidence and legislation, and also illustrating 3 different kinds of science: the tobacco, smoking. The research from a medical point of view was crystal clear when it came mainly from the US, from Surgeon General, etc. So we had the evidence in terms of smoking is not a good thing. In order to get to legislation, you need political decision makers, basically to have national legislation, but also how we did in the International Tobacco Convention, but also how you have different rules and legislation in countries where you can smoke, taxation, etc. So the political science understand when can actually politicians, when are they doing this and why are they not doing this? In Sweden, we have a tobacco legislation that is quite tough, alcohol as well, road safety as well. We have nothing on sweetened beverages in Sweden. Why is that? That's political reason. And one needs to understand the political landscape, why you can make legislation or not. But the third component, also get bit to challenge what kind of science we need, is behavior science. Because the most powerful here is actually what's happening in communities, the values and the cultures. If we don't have those with us, as I said with smoking, communities, certain groups, yes, you have the values that is really driving change, and for understanding how that is possible, how that is happening, we need also behavior science. So medical science, public health science, political science, but also behavior science. So not only medical and public health science, please.
Because, of course, you learn in medical school.
I know we're in the Academy of Medical Science.
No, it's fine.
I understand it's a bit undiplomatic, but...
It's good. And we like people with lacking diplomacy. I count myself in that group. And, of course, we learn in medical school, don't we, that, you know, we know all the answers to massively improve public health, but we just don't know how to get people to do them. So there was a question at the back, and then we'll go to an online question. Please introduce yourself.
Yeah, hi, my name is Casper Eriksson. I am Director of Strategy with the International Planned Parenthood Federation, and in a previous life I worked with Kenny in Southern Africa working on HIV prevention. I was really encouraged when Professor Abdool Karim framed the conversation in relation to the global risks, the things that are happening and that are shaping our future. I must say I'm a bit concerned now sitting here that we are reflecting a lot on successes from the past and things we did in the past, but we're not really presenting answers for the radical change that's taking place right now. And I really wanted to ask about, I must admit I've never heard of scientific diplomacy before, but I get the concept and I appreciate that. Certainly I know health diplomacy that Dr. Nordström has been championing for so long beautifully, but what can those two do in this world that's being framed, and are you not scared that you're being left behind, and have you got the radical strategies to be relevant in the future? Thank you.
Peggy, the future. Do you want to reflect on the future for us? Sorry, not Peggy. Quarraisha.
No, Peggy can go. It's fine. Peggy, they're asking you to respond.
No, I was going to give her a break. Actually, you go, because you multitasking badly.
Yeah.
Or Peggy, I don't mind. Anyone? Maybe we should ask. Let's start with. Have you still got the mic? Give us a sentence on what you see for the future. And you are the future because you're a good generation.
You can wait for our fourth paper that is looking into the future. We're looking into 4 different scenarios for the future. What will it mean for health diplomacy in the future? So if Richard will be happy with this, you will get it sometime next year.
Well, I'm asking because I think I'm looking for answers myself. I'm not that young, sadly, and I am a historian, so everything you're saying is beautiful. But I'm deeply concerned that there is a political revolution taking place right now, and it's not one that I'm in favor of, but the political landscape that you're talking about and how decisions are being made, the power brokers, that's changing. It's really changing fast. And I'm looking for answers. I'm looking, I think, across the sectors, we're looking for answers to how do we remain relevant? How do we use these tools that are being shaped, social media, to be out there and be heard in the right places?
But just to say,
if I may come in,
at that time either.
I
mean, it was difficult in 2002 when we established the Global Fund. Huge political tensions in between the UN and the G8 at that time. I mean, you described South Africa with the president. It was not easy. So, I mean, don't get the impression that it was easy before and now it's much more difficult. It is difficult now, but it was difficult then as well. I mean, I think what has really changed is the access and the flow of information and how we influence people with different kinds of information tools today. That's a big change.
So, Peggy and then Quarraisha. Peggy, go ahead, please.
If I may come in, I have worked, one of the proponents of science diplomacy from UNESCO, and I'm proud about that, and also citizen science. Diplomacy in science and science diplomacy and diplomacy for science. It has become very important now. For example, a lot of the conflicts, if we have science diplomacy, we could solve a lot of the conflicts. We just, had a program on how to solve the Nile River, the conflict along the Nile River, shared by so many other countries. We brought the scientists together to look at it from a scientific point of view in terms of ecology, what benefits the river gives, why if somebody, decides to build a dam, what happens to people who are downhill or down or up. We're bringing a lot of perspectives. And we're also training diplomats. And I'm glad that my colleague here was a former diplomat. Many of the diplomats are not scientists, and they do not understand scientific evidence to lead with diplomacy. So again, this is another area where we are training them, and that maybe answers some of your questions in terms of the geopolitics that we have now. How can we as scientists come together, not only natural scientists, but also social scientists and communicators coming together to look at the evidence-based that we can use in solving some of these, problems in the world in terms of maybe conflict or shared resources, or peace building, or even science. The diplomat. How do we use scientific information, or how do we disseminate those data? Very important. So thank you very much for that question.
Thank you.
So, Casper, you ask a very important question, and I don't think there are easy answers to it. And certainly, going back to what Mohammed was saying, it's not just about the knowledge we're generating within health, but it's what knowledge do we need and how do we generate that knowledge that really benefits society. It's about uplifting all the kind of disparities we have. So we've reached a point where trust in governments are failing. And then you've got so many pieces that I tried to mention earlier. But I go back to an African proverb. When faced in this uncharted terrain we find ourselves, where there are multiple things converging, we don't have easy solutions to it. It's partly an African proverb, partly what I learned as being an anti-apartheid activist, is that these battles that we need to fight are not going to be won overnight. But we have to, for survival of humanity and for planetary health, take them on. So they, like the ultimate test we're facing, and they're all kind of converging at the same time. So the African proverb was around the power that an individual has. So you don't have to be a scientist, you don't have to be a politician, but we all are members of civil society. And what power each of us has, like if you don't appreciate the power you have as an individual for change, then you clearly have not spent a night with a mosquito. So you spend time in Africa, so you know that. So that was one. And it's just the thing about, we have to try, each of us, every day, because the stakes are so high, to keep trying. And when I first became an anti-apartheid activist, I never dreamt I'd see democracy in my lifetime. But it mattered, as with generations before, that we stood up for what was right and made our voices heard, whatever that cost is. So I think those are important. Anders was talking about social movements that contributed to anti-tobacco legislation or our response to HIV. We've seen less of that in pandemics. We've seen less of that. Kenneth was talking about legislation, and we saw how, in the face of AIDS denialism, the judiciary was so key to PMTCT interventions become available in South Africa, to some extent antiretroviral treatment access. So judiciary is important, free press is important, free speech is also important. And I think today those are the fundamental truths that are under threat. And we cannot afford, as individuals or societies, to not protect those freedoms. With those freedoms come responsibilities, and we cannot thrive if we don't have free speech, if we don't have free media, if we don't have free judiciaries, and that we don't have accountability mechanisms for people we vote into power. So I think there's a certain amount of complacency that has set in terms of we vote and we put our lives in the hands of people we elected, that we have to rethink that. We have to rethink it when we're facing this existential crisis that we have on our hands. Thank you.
Thank you. We're going to go to online now, question online.
Thanks, Tom. This is a reflective question comment from Professor Amos Vertoken, and he writes this: I wonder how much we as scientists are improving efforts to understand how diversities of contexts across different parts of the world inform how people in various communities understand or appreciate science, or how it is communicated, as well as how those contexts should guide the application of scientific findings within those communities. So how much do we really take account of the diversities of context in our work in science and communication?
Who would like to start with that one?
I can.
Go ahead, yeah.
I think we, and I partly mentioned this in my previous comment, like we are not trained in engaging with communities, and that's definitely a missed opportunity. I think we need to be more proactive in terms of trying to make ourselves understandable as researchers to different cohorts within the community. I think many scientists think that publishing in high impact journals, or I don't know, doing another talk for other researchers is enough, but that is not enough. I think we need to improve our impact and evaluation system so that there is more rewards and incentives for communicating our research with the public. I can say, as an early career researcher, my university would love for me to publish another paper in the Lancet because, you know, it's good visibility and so on. But my university might not necessarily be very interested in me publishing another op-ed in the newspaper of the city, because that doesn't garner any citations. That is not really calculated in evaluation and assessment frameworks. So there's a whole ecosystem that can facilitate that, but we don't always have the necessary metrics and tools around it to incentivize it, unfortunately.
Thanks, Mohammed. Of course, in the UK, those who are familiar with the research excellence framework here, we do now have measurement of impact, and that's why it was so interesting to see your reflections on that. But it's really interesting what we mean by impact you talked about things going through to policy documents. I think for our exercise in the UK, even beyond entering policy, people really want to see lives saved, livelihoods saved as well. Anyone else got any thoughts on that? And before we come to the last couple of questions in the room.
I mean, a couple of reflections going back to my time in Sierra Leone during the Ebola outbreak, two things. One, in terms of science and community engagement, that was, I mean, we know how Ebola was spreading. We had the scientific evidence for that, but how then to engage with the communities and advise the communities and get an agreement with communities to change practice, how you took care of the people that had passed away. That was quite a tall order. And what I learned then when I came there was talk with people, not talk to people. And that was a science in itself. I mean, we have the tradition that we think that we can, especially as scientists, speak to people. Instead of speaking with people, we got the confidence, and then that started the movement around what was called the safe and dignified burials. Another example from that time was when we got the Ebola vaccine. That was a research trial happening in Guinea, very successful. So we were then allowed to use the vaccine also to be used in Sierra Leone to end basically the outbreak of the last cases there. Then this became a political issue. The Minister of Education, he was not very keen on the president. So he basically went back to his village and said, I don't believe that people should be vaccinated, even if we had the scientific proof for this. So that was then used politically. And then you need to understand, again, sorry for coming back to politics, how are politicians working? A key thing here is conflicts. You need to have a conflict if you're a politician. You can't, we love to agree. Politicians do not love to agree. They would like to have a conflict with opposition. So, I mean, you need to understand, again, this dynamic of politics and how you can then work and see what is resonating with the politician. One politician that taught me a lot was Joy Pomafi from Botswana, former minister, and done a lot during her lifetime. She said there are 4 Ps. Of course, people who are going to vote for you. Some partners might say something to you. The peers are extremely important, your other minister colleagues, what they are saying. And if you do your homework and know what they are saying, you can use that when you speak to your politician. But the most important one was sort of more your private history. My prime minister, for some reasons, is interested in mental health. I know why. So if you do your research, then you can achieve quite a lot. But do that and don't, in some way, disrespect that there is a logic also to politics. Don't just bang the evidence there. Try to understand what is helpful and what works.
Thank you. Okay, so we're getting towards the end now. We've got, we're going to have 2 final questions, if you can keep them brief. I think the gentleman there has a microphone, or did have. He's had it about 3 times and keeps losing it. And then Shakila at the front. If you can keep the questions short, we'll do the 2 of them in one go. And in answering them, we'll allow each of our panelists to include their concluding thoughts. Except Mohammed, we've lost him. Whether he will rejoin us, I'm not sure. But let's go for the 2 questions and then final comments from the panel.
Andrew Tompkins, Global Health, UCL. I have to say that this has been an outstanding and inspiring seminar, particularly Professor Karim. Thank you so much, and a colleague. My question, we've talked a lot about communication. We've talked a lot about resources. Can you give us some examples where the excellent quality of communication that you and your colleagues have achieved has actually resulted in release or provision of resources at the governments and the countries in Africa that you've been working in? Because it's important to see impact in understanding. It's important to see impact in action. And it would be so helpful because you have a lot of experience that other people could learn from.
Thank you. And Shakila?
Thank you very much for the inspiring lecture. Shakila Tangaratinam, Professor of Women's Health and incoming VP International for the Academy. I would like to have the panel's views on the massive shifts in the funds, the funding models, and the priorities that threatens the fabric of global health research, the health and outcomes for countless individuals, as well as the structures, as you beautifully showed, have been painstakingly put over decades. What can those of us who are here, who have years of experience, who have feet on the ground, and who walked down the diplomatic corridors, people like Richard here, how can we come together, and of course the academies, come together in order to preserve what we got and then to continue to progress? What can we do? This is a question that's asked every time I meet someone who works in the global health research. What can I do? What can we do together in this space? It'd be good to have the views of the panel.
Okay, thanks. So, Quarraisha, let's start with you. Question on...
Right.
I'm going to
both need
simplify
another 1 hour
no,
lecture.
No. You get
each,
three,
but it got
three
3
sentences on one on an impact release of resources and one on what more we can do together as academies and global communities.
I think on the that we have to think about HIV as a bit different from other conditions that we have. And I think part of the facilitatory mechanism of Global Fund, national governments, etc., meant that when evidence became available, most governments were taking that. When guidelines became available, they were adopted. So that's what we have. I think in COVID-19, the pandemic treaty, we saw a whole new thing come out. And I wanted to make the second point around the balance we strike between looking at research that has impact and sort of mission-oriented research and curiosity research. We would not have had mRNA technology if we didn't have curiosity research. So it's a fine balance between the kind of knowledge we need to be generating that's just curiosity-driven versus the one where here's the outcomes we need to be shifting and changing. And to your point, Shakila, on the funding, I think what we have learned at CAPRISA, the importance of a diversified funding base, to look at different funders, not the traditional funders. And so right now we're doing less from US government bases, looking at philanthropies. But also, we've seen the public very keen to put in money. I think national governments have to commit. There was a figure of about 1% of the GDP for research. That hasn't happened in any African country. We have to keep working at those things. Thanks.
Thank you. Anders?
No, just one comment on that, and again, possibly a bit controversial on that. I'm thinking around 4 big paradigm shifts for global health happening right now, and I will only speak to the last one. I think we're coming to the end of the developed assistance era, and I think we need to face that. I mean, we've been lucky what we have achieved during the last 25, 30 years with massive of resources globally, but even more resources at the domestic level. I mean, to see what South Africa is doing, spending today, is of course most important. And what we begin to see is, of course, that national government is putting more money there themselves. I mean, the call that came out from the meeting in Accra now quite recently, health sovereignty, but also end of dependency. I think that's good. The way that the US and the UK and Swedish government have quite abruptly ended the funding for service delivery program on the ground, I think is close to criminal. But long-term is, of course, the right direction to go. So the solution is then instead much more of domestic financing, and research, of course, needs to be, I mean, we need to make the call for this being a national priority, that governments need to prioritize investment in research and in innovation to be able to develop their countries, but also the global community. And some of us speak today also about what we call global public investments, that we need more global resources to investing in global public goods and research, and of course one of them, but that should not come from aid. And I think we have a problem with the legacy that everything we have done in terms of global health has basically been coming from this so-called aid budget. I think we're coming to an end, but we need now to have a conversation in terms of how to get different kind of funding, but then we need to be a bit clear both for what and when. Thank you.
Yeah.
Thank you. So
I think I want to come in to say that we need to have joint partnerships. For example, a good example is between the African Academy of Sciences and the Academy of Medical Sciences of the UK, working together, pooling our resources together. I think we need to work more together, even globally and in Africa. And another, example is that, yes, government should give 1% funding for science in Africa. But the leaders or the governments are saying that if they don't see the impact of the science, how do they fund it? So the onus is also on us as scientists to make sure that we provide the impacts of what, ever funding we get. And we need to have long-term, as indicated, long-term funding to make an impact. So this is a time to pull together. And I'm saying academies, tours, AAS, all these academies coming together. And because we go to the same donors, so why don't we get together, pool our resources together and make, an impact? This is the paradigm. This is what we need to do, globally, because the money is not there. Even if we think about philanthropists, they come with their own agenda. It is not for us scientists. There are things that we cannot publish because they give it, or they want to use it. So we need to rethink about global funding. We need to rethink about how we can pull together, as a community of experts or community of academies to be able to do global research that will benefit all. Thank you.
Thank you, Peggy. Mohammed has disappeared because he had to get a flight from Chicago. I think he's going straight to Washington to engage with policymakers there. But so we're going to come to Richard for his final reflections, and then we'll close out in the room here.
Very quickly, thanks, Quarraisha. Thank you, Anders. Thank you, Peggy. Thanks to all colleagues and friends at the Academy of Medical Sciences, Laura in particular, and to my colleagues at the Lancet who've helped so much. I just have one observation. Quarraisha, I was in Durban for that International AIDS Conference back in the year 2000, and it was a pivotal moment in the history of the AIDS movement and the pandemic, because that was the moment that Africa became noticed, and it hadn't been before, as you said. And I loved your conjunction of those three forces of activism, science, and solidarity. But I think there was an additional component, and I'd like to propose to Anders that he adds it to his list of the tricks and the tools for navigating the political process. Because I think what really made the difference at that conference, and you'll remember at the very beginning, in the opening ceremony, an 11-year-old young boy called Nkosi Johnson took to the stage. And at the time, he was a young boy who had acquired HIV, and he had lived the longest. And he gave a speech to the whole conference on the opening evening, as I recall, and it broke the audience, because suddenly we had a story and a human being who embodied a disease that people couldn't grasp. We didn't understand all the biology. We didn't have treatments at that time. But here was a young boy who stood for the challenge that we faced. So the story, so the word I would like to add to your tricks and tools, Anders, is stories, because I'm the first one to say that papers in the Lancet aren't going to change the world alone. I think we're part of it. We're part of it. But we have to turn those papers into stories that touch the hearts and engage the brains of those with power. And that's how we hold them accountable for their promises and their commitments. It's been a fantastic afternoon, so much to think about. Thank you very, very much indeed.
Thank you.